So hi everybody, this is Katie Obright, your host. I have a really good two-part series lined up for today and then the next episode that's going to be released. So I have Rusty Bishop here from the VA Palo Alto, and Rusty is going to tell us all about his experience in his primary care setting. But just a brief bio about Rusty. Rusty Bishop currently serves as the VA Palo Alto Orthopedic Residency Director with emphasis on providing education and training in the realm of being a primary care physical therapist. He started his career as an Air Force PT with a heavy emphasis on a direct access skill set. Rusty has been adjunct faculty at Samuel Merritt University, teaching medical screening for the past 7 years. Recently, he created a primary care physical therapy training course as a 4-day course exclusively to work on medical screening, imaging, diagnostic ultrasound to better serve our veterans and physicians in the primary care setting. As a federal employee for 11 years, he has spent significant time working on ways to work upstream as a frontline provider managing MSK conditions. Rusty, thanks for coming on. How are you doing today?
Doing great. No, thanks, Katie. Thanks for having me. Appreciate it.
Awesome. And you were actually brought to me by Katie, who is one of your current residents. I know her because she was one of Lance Mabry is my he's my imaging guy for Redefine Health Education. And Katie was one of his former students. So
Yes.
I know that Lance and Katie are actually presenting at the APTA North Carolina. There's a fall conference, which is at the time of this recording, which is mid-October 2022, is coming up this weekend. And when I heard about that, I was like, you know what, I really gotta interview her with her experience as a new grad. But then she was like, well, a lot of these things can be better answered by my director, who is you. So thanks so much for coming on. I'm excited to hear about your experiences.
Yeah, no, like I said, I'm really excited to be on here. I think that what you're doing with this podcast is amazing, and just getting awareness out there about the primary care PT side of things and the system in general, I think it's amazing to be able to touch a lot of people and be able to have people listen to what's going on out there.
Yeah, for sure. So one of the things we had talked about just before we started recording was my mission. And really the mission. So I'm the current education chair for the primary care special interest group, which is housed in the APTA federal. And, you know, my mission and our mission is really to drive home this model of physical therapists functioning as primary care providers, whether it's in a team-based integrated primary care clinic with other, you know, healthcare providers, my personal preference, or if it's really just taking the fundamentals of the primary care model, thinking comprehensively about the complete patient, and just taking that model and making it way more mainstream than it currently is, whether it's within the VA or within the military or I really want to see it as mainstream everywhere. So Rusty, just tell everybody a little bit about your background and how you ended up where you are today.
Yeah, so I guess my background, I've been a PT for now almost 12 years, graduated at Samuel Merritt University. Started off actually doing a residency in PNF at Vallejo Kaiser. I was really interested in the neuro aspects, but I did my internship, my last internship at Travis Air Force Base with the Air Force, and under a person named Major Sampson, Jeremiah Sampson. He went through the same fellowship at Kaiser that Lance went through. So just a little bit later. So my training during that internship was really focused on medical screening and being a direct access therapist as an intern. And it really empowered me as a early, student, and then also an early grad to understand that the skills that I had to be a really good direct access therapist. So even as an intern, we had capacity to order imaging, really manage our patients in a way that we were taught in school that I hadn't seen in the private sector. So from there, I decided to join the Air Force. And on my wish list, I was thinking, I was okay, I'm young, I'm gonna travel the world, I'm gonna go. So on my wish list, to put everywhere east of Colorado. And then I ended up getting stationed at Travis Air Force Base, right in my backyard. So it ended up being a blessing in disguise because I got to work with Jeremiah Sampson for another year. And he developed this internship program and I took it over. So we were training students again to be really good at direct access therapists and seeing how good early, like interns and early grads can do in this setting. So that's where a lot of my passions came from for medical screening. And when I started teaching at Samuel Merritt University, and then I transferred to the VA, and right away saw a lot of challenges with the biggest healthcare system in the country. Starting off where I was working, it was about 3 to 4 months just for patients to get in to see me for various reasons. And so the first 2 years of my career in the VA, I was treating a lot of chronic pain, and it was really challenging because a lot of these patients had been through so many aspects of our system, and then they come to us, and then maybe they had been to PT in the past, and I always felt like I was working uphill. Like it was really challenging to make progress in some of these patients who have really been frustrated with the system. And so from then we moved to a new building where we actually had the ability to have interns, and we started to work upstream and started to work on getting interns and physical therapists with primary care to see people right away in sort of a modified direct access at that point in time. And then we've had this acute program where if they have anyone has an acute pain, then call a nurse triage line and see myself as a PT as well as our chiropractic team. We actually team together, even evaluate patients together as more of a team approach. And the staff here, our primary care staff, has loved that just option. And so currently now we have I'm the director of our residency here, which has a focus on primary care. So now we have the resources to be upstairs coexisting with our physicians, nurses, social workers to really provide a really holistic approach for our patients. And part of the goal that we have is, we believe as physical therapists, we're so important. And what we do is really important. But part of our role is to take away some of those MSK patients from our primary care providers so they can focus more on some of the more medically ill patients. So just being better team members to our staff upstairs to just try to help the system get people seen a lot sooner and help them navigate the system if we can't help them. So kind of acting as almost like counselors in a way versus maybe what's seen before, which is doing a lot of interventions for a long period of time, but more just trying to pinpoint where does this person belong in our field or someone else. So that's been part of our goal.
Awesome. Awesome. It sounds like you have a great program there. So I'm going to back up a little bit and ask you a few more questions about your experiences along the way. So one of the things that you had mentioned was you, just like me, had the luxury of being able to kind of experience and start off with this model in the military. And isn't it hard to see what it's like when you don't have that?
Oh, 100%. I mean, even when we started in the VA, I couldn't order imaging. The idea of what physical therapy was this, I'm a stretcher, I'm a strengthener, and that's kind of what it was. That I wouldn't even get patients that I could treat really well, like acute radiculopathies or things that, because it wasn't even perceived that I could do that. And
Right.
in the military, it was really like, hey, MSK, you got it. You're
Right.
managing this. So.
Mm-hmm. Yeah, I have found the same thing. And one of the things that we've talked about before on this podcast, but just in other places is I feel like my entry level, so I went to Temple University, my entry level DPT program prepared me really well for working in any setting. Especially like a direct access orthopedic type setting. I didn't have any additional training. This is a common misconception about when you enter the military as a PT, that you have to do all this additional training because entry level DPT programs just aren't cutting it. Well, that wasn't the case. I had plenty of training and all the things that I needed to do, didn't have anything else advanced, and went straight into working into that environment. But the difference between what I was able to do there was I started my career being able to do all of the things I was taught to do in school. Whereas when you go out to some of your other, maybe more private sector clinicals, you're kind of taught this model that you're not learning, being forward thinking as a model that you learn in school. So it's like, it's very difficult because once you get out into your clinicals as a student, you're learning things a little bit differently, or you're learning that your scope is smaller than what it seems to be when you're in school. And so you're not maximizing that. So then when you get out into the field, you're basically just kind of repeating that same model. Do you think that that's part of the problem? Do you think that the one of the problems with the lack of the primary care mentality is just this, physical therapists and physical therapy corporations perpetuating that type of sort of limited model? Do you think that's part of the issue?
I mean, 100%. I mean, I know there's a lot of variables that go into it, like, insurances, what are you getting paid for? A lot of those things that come into play. But I 100% agree. It's like the wheel, you can't get out of it, and I think as long as, incentives are driven through insurances that, you have to do certain things. For instance, we do diagnostic imaging in the federal system, and the reason we do it is not because we want to diagnose everyone. It's because we want our physicians to perceive us as an ability to evaluate and even send in patients to us before considering an MRI for things like shoulder and knee. So really to capture patients to early on, as that was an early on issue. But in the private sector, like what's the incentives to even think about that? I mean, you don't get paid for it. So I think incentives drive a lot of our practice, and it seems like 100% what you're saying is we're in this wheel of the same thing happening over and over and not really getting out of that to really be more managers.
Yeah, for sure. So do you think that new grads who come out of school and they're able to practice in this model, that they'll be set up for success if it does become more mainstream, or do you think it doesn't matter?
I think I had the same experience that you had. I felt like my schooling prepared me to right away be in that system. It was just a matter of, I'm in a place where I could do those things. And
Exactly.
so I totally agree with you. So I think it's more about being in these settings that you can actually use those skills and then you build them. Most people, I think, when they go to the private sector, they might not worry about it, the medical screening aspect, or if something comes up, it might be like, well, go see your doc, versus for us, because we have the ability to, we might think about, okay, now let me think about what system is involved, and then let me think about how to package this to the right physician or the right person so they get the right care, and I'm going to follow through as they go through. So I don't think you even have the opportunity to do that in the private sector. So
Right, exactly. So pre-packaging, let's talk about that for a second. I talk about this a lot in my courses and just in my practice in general. But one of the things that I've been working on lately is beefing up the rheumatology content in my primary care courses. And so I've been working with a rheumatologist, and just one of the things that we've been going back and forth about was like, okay, you're super busy. The American College of Rheumatology specifically states these are the things that are prioritized or what should be frontlined for rheumatology care. And then things like osteoarthritis really should be kind of down on the bottom of the totem pole, because if we send every possible, muscular or joint pain issue, they would be inundated. So what can I do? What labs can I order? What imaging can I order to set you up for success, and, put it in a little present on a silver platter with the tied up bow to make sure that that patient is not having their time wasted before they get to see you? What can I do for you? And so we've been going back and forth on that. Have you come up with any specific, I don't want to say algorithms, but like, okay, if we see this type of patient, this type of specialty clinic might want this type of imaging or this type of lab work? Like, have you come up with anything in your current setting for that?
I mean, definitely for things like, I'll give some examples. So, for instance, a really common one is like cervical myelopathy. So, if you examine someone, they get the upper motor neuron positive tests, and you're thinking, okay, something is going on that needs care. So maybe I'm thinking, okay, I want to send them to neurosurgery
Mhm.
if it's really severe, to the ED. But um, so I potentially, for that patient, my options are, and it depends on the system you work in. In some systems, it's okay, just send them right to the ED. In some systems, like where I was at Travis, um, I could send them right to an MRI. So I can set that up. And then they went right the next day, 2 days later, they went to neurosurge. They
Mhm.
had a surgery right away. So I
Right.
could set them up with the MRI before, which
Mhm.
is what they would do anyway.
Mhm.
Um, so absolutely. And I feel like, packaging also, depends on the providers and their personality.
Right.
So in our system, having a lot of providers, depending on who I'm talking to, I might package things just a little bit different,
Mhm.
um, depending on what's going on. But I'm always saying things um, that are saying it's not. I'm getting these non-MSK findings, and I start to give them all these things that are like, okay, I'm really concerned, and I might even say some of those things too, like, hey, I'm really concerned about this patient, and then I have a very good list, like I'm a lawyer and I'm building a case, and
Mhm.
they can't turn me down, and
Mhm.
so now they have to see this patient.
Mhm.
So I totally agree with you, that depending on where you send them, the packaging is a really important thing to make sure patients aren't just, oh, you're fine, and go on your way.
Yeah, definitely. And I think that one of the best and easiest ways to learn how to do that is call them and ask them what they want. I have found in my practice from clinicals from the time I was a student in the clinical setting where I as a student was thinking like we should probably like call the orthopedic surgeon, right, about this. And I just kind of was like, shouldn't we talk to them about what they want or what their opinion is, and like shouldn't we talk to them in general? And I just found I have found that that doesn't happen as often as it should. And I get it, everybody's busy, it is a busy world out there, but good providers, good healthcare professionals are going to want to hear about their patients, they're going to want to hear about it. And so I over time have just picked up the phone and called, and sometimes I'm able to establish a great relationship where I can, text somebody directly and be like, hey, got this patient. This is what I'm seeing. What do you want to do? And then they respond right away. And then other times I have had this happen to me where I've called before and asked, it was really weird. It was an orthopedic case, and I was asking some specific questions, and it was like an MA on the phone, and I could hear the orthopedic surgeon in the background, literally telling her what to say to me on the phone, and I was like, "Is he there with you? Just give him the phone. This is ridiculous. Like nobody deserves to be disrespected like that." Or I just don't even understand that. And honestly, for me personally, I won't tolerate it either. So like I make it very clear that like I'm a healthcare professional. I deserve to be respected, just like you deserve to be respected. Let's talk about this as equals. And I think that that's something that the physical therapy community in general struggles with. Have you found that in your practice at all?
I mean, 100%. That solves so many issues. Just either picking up the phone, or we have a team system where you can just quickly message people. I
Perfect.
mean, the phone is a lot better, but and or even virtual
Mhm.
meetings. But yeah, I mean, 100% to be able to learn. Like for instance, I had an individual that had these cysts that were in his upper thoracic spine, and we looked on ultrasound and we saw there's like a tail going to like about T4 T5, and I was like, man, I'm not sure what to do with this patient, and also what image to order. And so we were able to talk to radiology, and they said, yeah, you can order a C spine MRI, we'll capture it, just make sure you put that in your notes so we can see how the depth of those, if there's anything. So but before, I think early on in my career, I think at Travis actually was really easy. That was kind of part of the culture. It was just call people,
Yeah, absolutely.
but maybe different when I came to the VA. But I think that's a huge piece of it, is just really trying to communicate really well, not being afraid to talk to a lot of disciplines and asking,
Mhm.
here's my concerns. Now, what do you need from me? How can I help this process along?
Yes, exactly. And that is exactly we definitely see eye to eye. We might need to make this like a two-part episode because I feel like I still have a ton that I want to ask you about. So, I have always said that. I have always said that it is so important for everybody just to kind of be on the same page. And if you have the culture there in your workplace to support that, it's our responsibility to set an example for the next generation of healthcare providers, for our students, for our residents or fellows, to just that's a standard. If you have a question, you ask someone else who knows better. That's it. We don't know
Yeah.
everything. They don't know everything. Let's all get on the same page so that we can make sure we're doing the best possible job to serve that patient so that they have the best possible outcomes, but also that, we know that physicians are extremely overwhelmed. It's only getting worse. Let's
Yeah.
help them. And so the way that you tee this up for them, if you're having a question about like, don't communicate often and you want to start communicating, I would just tee it up as, hey, I have this patient. I really want to help set you up for success when you first see this patient. What can I do for you before that patient gets to you to help you? That is probably one of the best approaches that I've been able to take. Do you have any other advice like that?
No, I mean, I think it's, I know, I really don't. I think it's just a matter of figuring out, all the different avenues we can communicate,
Mhm.
whether, some systems, the phone is really easy, some is, and just being able to get used to making that a habit.
Mhm.
No, I think everything you're saying, we don't, if everyone in the system, and this is super idealistic,
I am the same.
if everyone just understood what they know and what they don't know, and that they can ask for help, that would already solve a lot of issues.
Mhm.
So I'm on the same page with you.
Yeah. So now I really want to hear more about just the evolution of how your primary care program started in the, well, let's even flash back a little further. Let's dialogue a little bit about your experience in the Air Force. So you mentioned a number of times the words or just the phrase direct access. Do you feel that there's a difference between the term direct access and the term primary care PT? What are your definitions of both of those things?
Yeah, that's a really good question because even in I say direct access, but even in the Air Force, most of our patients I saw came through referral. So I mean,
Same.
but the Air Force has obviously all these programs where we would go up to flight medicine and help triage some of those patients, and then they started to go up to more primary care to try to capture these patients by having like a nurse triage line that if it was A, B, and C, that they would see these patients. So that's a really good point because I say direct access, but the primary patients I saw were referral based. I just had the ability to order imaging, labs, pharmaceuticals if I wanted to. So I had just more capacity there, and I had more maybe my the belief of what I was going to be doing was more management from just the providers around me.
Mhm.
Um, but yeah, that's a really good point. And so I don't know. I mean, I think in my point of view for the direct access versus primary care, when I think of primary care, I think of the ability to be at least co-located, because I think there's just what you just said. If we want to work together, if I have some questions, I can just go over the hall or really close and ask that.
Mhm.
So I think of not necessarily like I'm in my own establishment what you could have, but I in my opinion, I'm thinking in our VA system, which is so
Mhm.
complex and so big, that the biggest help is to be co-located with our physicians, nurses, and our teams. But I do believe, obviously, the the primary care side of things is just a frontline provider
Mhm.
that is maybe the first person to see someone and help triage them. And I think triage might be help a little bit. Is it's not necessarily that I'm the person accountable for helping this person, but really to understand where do they belong in our system.
Mhm.
And I think that to me is the differentiation between maybe direct access to primary care in terms of maybe some of the roles.
Totally. So I talk about this a lot too. So that my definitions would be, and these definitions I feel like are just kind of evolving. And I think they've evolved a lot in the primary care special interest group. I think when it initially started, they probably had more of the mindset because a lot of the founders of this were military or VA. Probably a lot of them were thinking, okay, primary care PT is like frontline provider, neuromuscular skeletal evaluation, Co-located in primary care is awesome. So my definitions have evolved a bit over time also. Direct access to me means you are just able to see a patient without a referral, which that can mean anything. That's just kind of, varies state by state and blah, blah, blah. Um, Primary care PT to me is more of a mindset of comprehensive care for a patient within our scope of practice. So when you see, so one of the things that I posted last week, I had a patient. It's actually one of my husband's. My husband plays on a recreational softball team, and he this, of course, this stuff happens in rec softball. Most of the bad injuries that I saw when I was in the Army were just from like sports PT, them like going
100%.
out and playing basketball for PT one
Mhm.
day. But anyway, so playing rec softball, he was sliding in to a base, dislocated his ankle, fractured, like multiple fractures. And so I actually posted a video about, what can I possibly do for an acute fractured ankle that is not stabilized yet? Well, they relocated his ankle, came home from the ED, and he's having surgery this week. And my initial thought for him was, okay, he's going to be off his feet for a long time. We need to make sure he's breathing deeply and he is, doing good breathing exercises, opening up his lungs to make sure that he's preventing any sort of, vascular stasis or lung stasis. So thinking about his cardiovascular system, thinking about his mental health. Okay, this sucks. You're going to be off work for a little while. You've got a couple little kids running around. Like, you're going to be probably really upset that this happened. Let's talk about that. Let's make sure you have resources if you need them. Thinking about narcotic use and talking to the patient about, okay, you're on these narcotics now. Narcotics can be very addictive. Let's talk about ways that, wean off of them as soon as possible. Let's talk about other pain management options that are out there. So you cover all of these different, multi-systems education points that are related to the patient's function, but that are related to their overall health and well-being. So I'm not going to start initiating cognitive behavioral therapy for somebody with depression, but I'm going to talk to them about it and screen for it. And I'm going to make sure that they have resources available to them, make sure that they have referrals if and when they need it. That to me is the primary care PT mindset. And that's something that primary care behavioral health has done a really good job of doing, just making sure that patients are set up for success from a multi-systems perspective right from the start. You don't need to be an expert in every single PT specialty in order to have that primary care mindset. Every physical therapist should have that. But on the topic of co-location, I'm with you. It is 100 times better and more effective to be co-located in that same physical workspace as other primary care physicians, nurse practitioners, et cetera, for the patient and for you. So tell me a little bit about your experience working in co-located settings versus ones that are not and the differences.
Yeah, and we have a pretty good example here because we started our primary care, let's see, like 5 years ago, and we did that for a very short period of time. I was by myself, and I had a colleague, and he left, and I had 4 interns, so I was like, we're going for it. So we were up there for a little while to kind of show what we can do and sort of break some of the barriers down. But after that, what we did is we created an acute care or acute consults where, again, if they are seen upstairs, they can be directly sent to us. And then later we followed up with being co-located. And so the difference in those, like, one, you could almost call it like a modified direct access, because we actually had patients that were just coming through a nurse line and they'd be directly seen by us downstairs, which is a different location. So I think the difference is, one is when patients, you don't capture as many patients, because when they come in to see their physicians, first off, they're really scared, and a lot of them they want some sort of medications. There's certain things they want. So when a physician says, "Oh yeah, would you also be willing to see physical therapy today?" Half the patients are like, "No, I'm good. I got what I want. I'm out." And so you miss out on a lot of patients that way. So that's one thing that we discovered. And then also in our acute, we have such a high comorbidity rate, or a lot of patients with a lot of comorbidities who are very sick in different ways, but might have MSK issues. And for us to collaborate on someone who's sent to us with back pain, but we're concerned of something else, it is so much easier to just talk to someone right away, because even picking up the phone, they might be with the patient.
Right.
We could walk up, but they might be busy. And so you're built into the system and even into the diagnostic process. So for instance, we have one of our primary care physicians. He was the ED doc for a long time. And so when he sees a patient who has, whether it's back or knee or some sort, and he's not sure about the MSK versus non-MSK, he has us come in and we are part of the diagnostic process. Right. And so you have our ability to see patients without coming to the physicians, but then also the ones that do come to them and then they need help with. So there's a lot of avenues to help our patients holistically. I think when you're co-located, and we saw the difference just locally in our facility.
Mm-hmm. So do you still have the model where they have the nurse triage line that will send patients directly to the physical therapy clinic, or are you all in the primary care clinic all the time?
Yeah, it's right now we're working on it being more like more that it's the nurse triage just sent to us. Mm-hmm. I would say about 20 to 25% of patients that we see, it's just coming from a nurse triage line. These are the battles that we're kind of going after right now, because even us in primary care right now, and we're building our program up there, that the majority of patients we see upstairs co-located have already been seen by a PA or a physician. And we're realizing certain things are when patients are booked onto their schedules, they feel accountable to see that patient. Mm-hmm. So what we're trying to do right now, and actually Katie and Lane, our two residents, are the ones leading this, is developing a way that it's an easier nurse triage where we're capturing more of those patients directly to us, so that there's not this double dipping where those physicians can spend more time doing other things. Mm-hmm. So we have kind of both going on, and we're trying to get more on the side of that just coming from a nurse triage line. Okay. And that's what we're working on.
Okay, I have a number of questions specifically about the operation, but before I get to that, I want to ask about what is the patient's perception? Now, the VA, I am a VA beneficiary for a couple of things that were service related. So I understand how the VA system works. But I am also a healthcare provider and I understand a lot about models. So it's very interesting when I do utilize the VA for services. It's especially interesting as a younger female who appears healthy. So I won't get into my medical history. I had some really weird things happen to me, but I won't get into my medical history. But it's a really interesting system to be a part of as a young female who appears to be healthy. Anyways, so maybe that's a discussion for another time. But one of my questions is, and we talked about this in episode 1 with the Bellin group, what is the patient's perception when they see a physical therapist, when they're expecting, what is their perception when they come in and they see a PT before they're seeing their primary care physician?
Yeah, and I think that's one thing that helps with being co-located, because you're still in the same spot. So you're like, I'm still in the same vicinity as what is perceived in our system is, if I'm hurt or I have some sort of concern, I'm going to see my doctor. Mm-hmm. And that's what the majority of patients think. Mm-hmm. And so I think that's another thing at this phase of the game, is when you're co-located, they still come in and they're still are very open to being evaluated by a physical therapist. And I would say they still are very open to being evaluated by a physical therapist when they come see us downstairs first. Mm-hmm. But I would say, again, we lose patients that are like, there's a lower percentage that are more okay with that. Mm-hmm. Yeah. If that makes sense. So I say upstairs, we haven't had any issues with patients being like, I want to see my doc, because I think of that co-location. I think that's been really helpful.
Totally. So great point, and something that I want to emphasize. A lot of people, a lot of PTs, and I'm guilty of this. Young Katie, right out of PT school, I was like, PT can solve the world. It's going to end world hunger, and we're all going to live in outer space, and it's going to be great. So I really thought that, or I really felt that once upon a time. But the more I got into team-based healthcare, the more I saw literally being in that co-located space. Not only is it helping the patients because they're seeing all of us work as a team together, they also feel that they have a team of healthcare providers to address their primary care problems with. So instead of just having a primary care physician who, if you needed behavioral health or if you needed physical therapy, you would facilitate a referral to a separate distinct clinic, whether it's in the same hospital or in another building. You have a team of healthcare providers that are right there for you. And you might have a doc who you've been seeing for 30 years and you prefer to see them first. And that's perfectly fine. But then that doc might say, hey, we have this other staff member here that might come see you today. He's gonna come in and evaluate you. Would you be comfortable with that? And just the concept of showing your face and making an introduction and maybe talking to them even a little bit about their function, about what you can do as a PT. The Bellin Group has seen just that aspect alone facilitate more referrals to PT that have been followed through on, because they have an understanding of what you can do for them. People love to have face-to-face interaction. They love to build connections and establish relationships with people. If they're able to do that, they're more likely to follow through. And the final aspect is, if you have a group of physicians or nurse practitioners or whatever who are seeing patients frontline, and they know and have a thorough understanding of what you can do as a PT, they're going to be more likely to sell it to a patient that they really believe needs you. But being in that same space is just so important. And I really think that that's the difference that we're really going to see. So when we talk about the difference between models, we have sort of this direct triage model where somebody, either from an online booking system or a call center, like the nurse triage line that the VA has, that they can directly send the patient straight to PT. Then we have the patient going to primary care and then going to PT, depending on what primary care thinks. And then we have sort of this middle ground where the primary care providers, PTs, all work together in the same space. What is your future at your location where you see the most growth with this model?
Yeah, I mean, I would say the hope is that we have a model that does all three. Because I think if you just stick yourself with one, you kind of pigeonhole yourself. And so our goals are to increase the numbers of people coming from the nurse triage line, just with the purpose of offloading. But it's so important to co-treat and co-evaluate, because what you just said was so important, because a lot of issues come from just not understanding what each other has to offer.
Mm-hmm.
And we still, when I first, just in the medical system in general, a lot of the issues that we face, and I'm speaking to the choir on this, is I have this thing in my back called OA that's never going to change, and this is being communicated from a person like a physician. And us being co-located, all of a sudden we start to learn from them, and then they start to learn from us.
Mm-hmm.
And now the education that we provide our patients, even when we're not around, starts to change. So I think that piece of it is just so important. So I think our hope is that we would be able to do all three of these. But the current thing that we're working on is really just emphasizing more from the nurse to us. So building that part of it.
Yeah. Okay. Awesome. I love that. So were you in VA Palo Alto when they first started having PTs in primary care?
Yeah. So we were the first ones to start it. I'm in a Monterey, what's called a CBOC, a community-based outpatient clinic. So we we were the first ones to do it in 2017, and
Mhm.
then have this kind of modified direct access. And now what's happened is, because of this internship program that I've had for a while, a lot of our interns have gone out, done residencies, and now they're coming back. Now they're the ones moving things forward. And so now Palo Alto has someone working on that side of it too, and we're working on getting more solidified positions. Our residency has really helped just provide resources to be able to do it and to be able to educate, to give new graduates an avenue to practice in this setting.
Mhm.
And I think that's really, really tough to find out there.
Awesome. So, okay, how did you start it? Who did you have to talk to? How did you do it? Did you give presentations? Did you just talk to people face to face, emails, phone calls? Like, give me what the groundwork looked like.
Yeah, I mean, um, for us for the VA, a lot of it was, we're staffed with what's called two FTs, two physical therapists, and we kind of always had our head down, because we're just powering through patients and trying to do the best we can. So in the military, they developed these internship programs, and I was a part of it, and I taught in it, and that allowed for the ability to treat interns like residents. So we'd have classes built in, and so they're not just being workhorses. But what that allowed for us to kind of look above and at the future, kind of to get a little bit more bandwidth. And so that was crucial for us to start our internship program. And then it allowed us to start for me to communicate with our primary care providers. And really what the biggest thing was just building a really strong relationship with our head physician. And it was so strong that when I talked about this model and what we could offer, I didn't have a lot of I didn't have a lot of pushback. It was sort of like, okay, we just moved into this new building. There's a lot of space, so it was the right time and the right place for it. We didn't have a lot of resources at the time, so it was just like strike when it's hot. And
Mhm.
I think that would be my advice to anyone is sometimes we want things to be perfect, and we're like, we got to have the perfect thing. And the way I've seen things, at least in the system I work in, is if there's an opportunity to do something, sometimes those opportunities close. There's a window, and you got to strike in those times, even if it's not ideal or perfect, and make the best you can, and things can grow once people start seeing things. So really, it was building that relationship with our head physician, and I just kind of talked about what we can offer, and then that's when that first started.
How did you build that relationship to begin with? That seems like such a silly question. How do you build a
I know.
relationship? But
Yeah.
but seriously, I think that's what a lot of people want to know. They think it has to be this formalized process, but I'm curious, what
Yeah.
do you think?
Yeah, obviously it started, 2 years before that when I started the same building, and most of the times it started from just talking about other things besides healthcare. Talking about her life and her goals, and same with me. And I started having, at that point I had little kids, and I remember she actually knit a sweater for one of my kids, and I was like, it was just so nice. They had a baby shower for me, so
Aw.
I think a lot of the relationships actually really stemmed away from the medical side of it, and more on the personal side. And then I think what she saw is someone who was really dedicated to the profession, and she was getting a lot of responses from our patients that were doing really well with physical therapy. Because before I came and my coworker came, they didn't have a physical therapy there for a while, a physical therapist for a while. So a lot of patients were struggling.
Mhm.
So they saw this difference. Patients were giving really positive feedback also. And that was going on for 2 years. So she trusted me as a person, and I felt like she trusted me as a healthcare provider.
Mhm.
And so at least those are some of the basis that was built off of.
Yeah. So even just like, I think a lot of people think like, oh, you have to have a big presentation planned and all of this. And sometimes it really is just being a real person and making friends, being social and being okay with being outside of your comfort zone. I think sometimes PTs are just like, okay, we're gonna be friends with our PTs because that's what we know. And but it's really the people that want to learn about other healthcare professionals that are going to be really successful in building those relationships. Um, so so from that point, I'm curious now what the actual operation looks like now. So when you are co-located, how many days a week are you up there? Is it PTs are rotating, or is there one person that's staffed? How long are your visits? Give me an idea of how you would describe the operation to somebody who's just starting in the new clinic.
Yeah, and my role now has been kind of more on the education side of it. So my goal was kind of try to build these avenues. So I haven't really been upstairs in primary care since our residence started. So I'll speak to, and this is where Katie can come in, because I really want to empower her and our other resident to build this program. I think it's important for them not only to treat in there, but also to feel like they have an investment.
Yes.
So currently the way that it works, and we're trying to make improvements in this, and our biggest struggle along has been resources. So again, with only 2 staff, we've developed a modified direct access, but to take one person out of our clinic and move them upstairs has always been a challenge. But now with residents, we're able to do that. So what does it look like currently? Our residents will go to a kind of a nurse meeting or a teams meeting, and they'll let them know, hey, we're up there Monday, Wednesday, and Friday, because that's the bandwidth we can currently provide. And they're dedicated to that space all day. And they let the providers, the nurses, staff know, hey, we're up there to support you today. And so what they do is they try to kind of cherry pick the MSK patients that the providers and the nursing staff and those separate teams have. So the PTs are already kind of aware, and then they're communicating with these different teams on, hey, how can I help you today? Is there anyone I could take? And then so that's a part of the patients. I would say about 50%, and then 50% are just messages from them saying, hey, I got someone here. Can you take a look at this? Can you come over here? I have someone that has these things. I'm not quite sure. Can you help? Can we co-evaluate? So that's another portion of it right now. So it's sort of at this stage of the game, there's not like a set schedule yet. It's more of feeding these messages. And we have a resident and an intern that team together on 2 of the days. So our process is they essentially triage, and they see about at this point it's about 5 to 7 patients a day that they're seeing. And then we have because there's not a lot of time, sometimes everything is kind of clustered. We have our direct access, our acute. We have 2 acute pain slots every day, and we manage that with Cairo. So let's say one of our residents sees a patient at 11 o'clock who's coming in for acute low back pain. And maybe this patient came through the physician first, and they're like, hey, now let's have you see him. And then you tell me what you think. They're like, you know what, this person is a good candidate for PT. I've screened the red flags. Then we have actually slots they can come into either that day or the next day for treatment. So it's really upstairs. They have the opportunity to treat if there's time, but a lot of it is more triaging.
Yep.
Are they in our field or not? Is there someone else I need to get this person to that's not in our field? So that's the triaging part. And if they are in our field, is it someone that needs to be seen right away, or can I triage them more to a chronic slot? Or in the VA, we have the opportunity to triage to community care, or to other things like aquatic therapy, or things like women's health. So just trying to figure out what's the need of the patient and where do they fit in our system so they could best be successful.
Yes, exactly. And so I've asked this to other people before on this podcast and then outside of it. What's the benefit of a PT going through that MSK triage and screening process, a PT doing that versus a primary care physician or nurse practitioner?
Yeah, and I can tell you I have so many medical screening cases that, they were just seen by a physician. And in my opinion, it's not that anyone is missing anything. I think our system should be developed so that there's multiple tiers of people looking at things, and no one should be accountable for one. Everyone makes errors. We're human. But I think in terms of that triage process and medical screening, our background in musculoskeletal is so important when someone comes in with thoracolumbar pain that's maybe radiating out, and you're concerned of potential kidney issues, but I can go in and thoroughly screen the MSK system, and that way I can rule in or out that way, along with having time to ask the system-based questions.
Mhm.
So for instance, I'll get someone coming in and I'll go through the bowel and bladder. Hey, bowel and bladder changes? No. Okay. Any stool changes? No. Okay. Any blood in your stool? Yeah, actually.
Mhm.
And I go, hey, did you talk to your doctor about that? No, I didn't have time to do that. Oh,
Mhm.
okay. So I feel like, we have the time to really investigate maybe a little bit more. I don't want to say thoroughly, but if we spend 10 to 15 minutes talking to someone about their subjective medical screening issues, we can capture things that maybe weren't captured because of our kind of crazy, fast-paced medical system.
Yep, absolutely. And I think that others from other sites would agree with you. And in my experience and in just interviewing others, it's been pretty consistent that the physicians and providers that we work with in primary care, after they work with us there, they don't know how to function without us there. Has that been your experience, and that they're just so grateful to have you there? You're so grateful to be there.
I would say they definitely have had the luxury of, if anyone has acute, that we have. Um, they've had such an ability to utilize us right away. I think right now with our primary care, because Lane and Katie are residents, we've been up there consistently now, inconsistently for years, consistently for the last 4 months.
Mhm.
So I think that we're turning the corner where now we're seeing the days that we're not there. They're like, hey, who's here to help? They're pinging us nonstop of like, who can help us out? So I don't feel like I think we're going to be there very soon. And I think we're getting there, but I think that the consistency is something that we are finally having, and we're seeing these changes.
Okay, awesome. And um last little point, which in the VA system, a lot of people didn't know when, when I was in the army and I talk about my experience, they're like, "Oh, well, you don't have to bill in the army." It's like, well, actually, that you still have to code everything just like you would code it anywhere else. You still have to, and that is what generates your own RVUs. We have productivity requirements just like everybody else. It just might be a little bit different. So tell me a little bit about the billing aspect, the coding aspect. And also I remember one thing that was like a problem when I was in the army was they were trying to, because I was assigned as an employee, I guess, if you will, to the PT department, but I was working and I was a part of the primary care team. My codes were like going to primary care, and on the back end, like it got all messed up as far as like where the RVUs were going. So kind of explain any challenges, or well, explain what it is and then explain any challenges or advantages with it.
Yeah, I mean, you said it best. It's like, just because we're federal, there still is a billing system. We bill for evaluations, TheraX, all the things that you would typically bill for, very similarly to the private sector. Um, I think the challenge is, at least, I would say the challenge, at least on the side of the VA, is how to stay productive, um, while being able to do new programs. And I think that's where RVUs come into play
Mhm.
for us. And I'm not sure if this is kind of where you were thinking, but so for us, for RVUs, we bill, we do all these things that are similar to private sector. They capture that billing. That's looked at by analysts, and then kind of sent back to us as our productivity. Um, and so they use that to say, okay, yes, you're in the green, you're productive, or you're in the red, and you're not productive. And that matters to us, because we have to be in the green, or else, technically we kind of get in trouble. And so if you're in the red and you're trying to create new programs, it's really hard. And when you're starting primary care PT roles, productivity is challenging. You're building this program. So for us, in terms of RVUs, it's been just more challenging in terms of the productivity side of it, of being able to sell to our leadership that we're productive,
Mhm.
to be able to continue, even though, if you look at, we call it upstream, if you look at all the trickle down effect of everything,
Mhm.
it's insane that the money you're saving on imaging,
Yeah.
medications, it just goes crazy. So, in my opinion, if you see 5 to 7 patients, that's like seeing 20 to 30 patients.
Right.
Just the amount of difference you're making right away. But was there anything else that you were kind of thinking about with the RVUs?
I mean, that was basically my question was, do the PTs in the primary care setting, do they have the same productivity standards as a regular staff PT in the traditional clinic?
Yeah, and every VA, every VA is an island,
Uh-huh.
so it depends on. But currently, because we don't have any dedicated staff. Like right now, our leadership is trying to build it's called PAC team PTs, and they're
Yep.
dedicated to those positions. And we haven't been there yet. So just like in the military, we have to use our current resources to build a new program.
Mm-hmm.
So we've had to find innovative ways to do that. So for us, the ability to have an internship program and a residency is really how we had to do it. So that was our innovation of interns, their productivity comes to their CIs, residents, their productivity comes to their mentors. So
I see.
that was our way around it. But if we didn't, so for years I've been trying to do this, obviously for 5 or 6 years, and we've struggled because we don't have the resources to do it. So for us, it was crucial to build these programs to get the productivity to finally do it.
That is really interesting and really innovative. So I think that we'll talk to in the next episode, we'll talk to Katie more about her experience as a resident and kind of how that all works out for your program. But I think that what y'all are doing is exactly what we need. And but in my experience, just like you said it, every VA is an island. When you've been to one VA, you've been to one VA. So the whole VA system, there's efforts that are taking place like this all over the place, but it seems like everybody has a different way that they're going to do it, which is okay, because there's going to be different resources available to you based on your locality and your region. But are you aware that or have you been in communication? Is there any sort of internal network for packed PTs in the VA?
Yeah, this is a huge push for the VA right now. Mark Havern, the leader, and then there's a person, Ashley Castle. She's in Minnesota, and she's kind of leading this charge. And we're part of the first cohort of this. And so one of my staff, who's one of our primary care folks who's done a residency, he meets once every couple of weeks to talk about it. So there's an internal network
Awesome.
of this and communicating. Here's how I do it. Here's how I do it. So that's been really helpful. So that network is trying to be built, and they're doing a really good job, I would say.
Awesome. Great. So if you're in a VA and you don't know who to talk to and you're interested in implementing this model, where or who should they contact? I think I have an answer to that, but I want to know what your answer to that is.
Yeah, I mean, anyone who's doing it, but Ashley is really the lead for it. She is the go-to, and I know she would be able to disperse any information anywhere. So she has eyes over things. So that's where I would start.
Perfect. So Ashley is she just stepped down as the chair, but she's now she's continuing to work on the petition for the primary care board certification. So
Yes.
she was the chair of the primary care special interest group, but now she's working on the petition, and Evan Kelly is now the chair of the SIG. So if anybody has any questions about that at all, there's a very strong presence of primary care leadership in the VA primary care leadership in the primary care SIG. So if you have any questions about that, just either contact the PC SIG or you can email me and I can connect you with the right person. Rusty, thank you so much for this episode. I feel like we could talk for literally hours about all of this stuff. If anybody wants to reach out to you, or wants to follow you on social media, like what is your preferred method of people reaching out to you if they have any questions?
Probably through email.
Okay.
I'm not on any social media. I'm sorry.
Okay.
I'm off the grid on that way, but just
Okay.
my email is russell.bishop2 at
Perfect.
va.gov.
Awesome. And I will put that email address in the show notes for everybody if I didn't, if the transcript doesn't come through clear. But thank you so much. I really appreciate you taking out the time. It was great getting to know you and getting to know more about what y'all are doing out at the VA Palo Alto. Anything else you want to say? Any parting words of wisdom for anybody who wants to start implementing this program?
No, I mean, my biggest thing is what you're doing here is what's really important, is getting the word out. And so I really appreciate what you're doing. And, I think that you go to PT schools all over and there's a really lack of knowledge of this sort of role.
Mhm.
And I think, what you're doing right now is what's important, is getting the word out and getting people understanding what's out there and what we can do. So I'm really appreciative of what you're doing. And Katie is amazing. Have fun talking to her. She's awesome.
Awesome. Well, we're really looking forward to that next episode. Thank you so much, Rusty. Thanks for listening to the Redefine Health Ed podcast. Support our mission of getting more rehab professionals integrated into primary care by visiting redefinehealthed.com, subscribing to our email list, following us on social media at Redefine Health Ed, and taking one of our courses. All podcast listeners can save $50 on our Foundations for the Primary Care Therapist course or the Master Musculoskeletal Imaging certification by entering RHE Podcast, all lowercase, into the promo code section of the checkout page. Until the next episode, stay awesome, y'all.